as a professor many times, and I have many friends on the island. And as time goes on, I'm more and more impressed by both the people and the healthcare programs that you have, and the magnificent care for dementia. So thank you for hearing me today. I'm going to say a little bit about, I'm going to talk a little bit about molecules associated with frontotemporal dementia, lifestyle, burden of caregiving, the BVFTD phenotype, and some new work around therapies that I think will bring treatments and cures to the different frontotemporal dementias. Okay, next slide, please. Yeah, so good. So this is a model that comes from one of my mentors at UCSF, Stanley Prusner, and he won the Nobel Prize for this work in 1997. And what Stan said is that all degenerative diseases have a genetic or sporadic cause. I think in the case of Alzheimer's, approximately 60% is driven by genetics and epigenetics. And maybe another 30 to 40% is driven by lifestyle. I think a very important finding. We have learned from this model that we can take skin cells from people, convert them into neurons, study their own pathogenesis of a disease. Similarly, there are many simple model systems that allow us to study how Alzheimer's, frontotemporal dementia, other diseases progress. All of these, whether we're working in a worm or in a human, go through 3 stages. The first is preclinical, and that's the period in the case of Alzheimer's disease, which goes on for probably 20 years, when the bad proteins like amyloid and tau are aggregating outside and inside the neuron, but haven't injured enough neurons to cause symptoms. Early symptomatic is when there is enough of neuronal damage of synapses to cause subtle dysfunction. So for each degenerative disease, there's a different early symptomatic phase. In Alzheimer's, it's memory. In the case of frontotemporal dementia, it's behavior. In the Parkinson diseases, it's often sleep, anxiety, or mood. And then finally, there's enough of the neurons injured that we get a formal symptomatic phase that we call dementia. And I think more and more we are hoping to develop treatments in the preclinical period of the illness. The diseases are caused by abnormal protein aggregation, which kills synapses and eventually neurons. And these misfolded proteins spread from one cell to the next. Next slide, please. And this is the pathology that Stan Prusner said was spreading of abnormal proteins, and he was right. In the case of Alzheimer's disease, it's the amyloid protein A beta 42 and the abnormally phosphorylated tau. In frontotemporal dementia, it is either tau or TDP43. In the case of ALS, which is strongly linked to frontotemporal dementia, it is almost always TDP43. 2 diseases that I think of frontotemporal dementia spectrum that are caused by misfolded tau are PSP and cortical basal degeneration. We have Parkinsonian disorders associated with misfolding of the alpha-synuclein protein, This happens in the autonomic nervous system, in the brainstem core, before it ever reaches the midbrain. So before we ever see changes in movement with Parkinson-related disorders, we see changes that are psychiatric or autonomic. And then finally, the prion disease that Stan Prusner won the Nobel Prize studying in the 1980s causes different types of aggregations. So these are the different pathologic inclusions. They happen with each of these diseases in a different part of the brain. And where the brain is hit causes symptoms. And the fact that all of these proteins attack different circuits in the brain means that we as clinicians can separate one disease from another. So this next slide talks about something that one of our faculty has written, I think, quite beautifully about, William Seeley. And this is this idea, of network-based neurodegeneration. So each of these diseases, the amyloid and tau of Alzheimer's, hits the default mode network in the back of the brain, shown in a circle here, the right angular gyrus. In behavioral variant frontotemporal dementia, it starts in the insula. Frontal cortex can begin in an individual cell. It's so specific and focal. In the language that Judy is iconic dementia. Next slide. Good. So frontotemporal dementia is a common who get ALS, if they live long enough, are going to get frontotemporal dementia. PSP and cortical basal degeneration are tauopathies that are strongly linked to frontotemporal dementia clinically and pathologically. And finally, chronic traumatic encephalopathy. So TDP43, one of the two major frontotemporal dementia proteins, occurs in many people with a diagnosis of Alzheimer's disease over the age of 80 who have plaques and tangles, maybe close to 50%. The Keith Josephs at Mayo Clinics has said that this TDP in people with Alzheimer's disease is probably a late form of frontotemporal dementia. So I think I emphasize a lot this slide because I think there's a lot of new thinking that suggests that maybe frontotemporal dementia is common even in the very old in people as co-pathology to Alzheimer's. Next slide. And this one just shows the major subtypes of frontotemporal dementia. The behavioral variant, just a little bit, yeah, beautiful. Okay, let me, which is bilateral frontotemporal insular, the semantic variant, anterior temporal, and the non-fluent variant, left frontoinsular. Amazingly, where the atrophy occurs is a strong predictor of the pathology. So with the non-fluent variant, we think that we can predict most of the cases in terms of the molecule preclinically, clinically. So if someone has a non-fluent aphasia at our center, 85% of them have tau as the underlying protein. Most of those people have cortical basal degeneration. Some of them have Pick's disease. Some of them have PSP. If you don't have tau, the majority of our cases carry the progranulin protein. I think very, very high prediction in the non. Associated, very strongly genetic, and about equally divided between TDP, tau, and about 10% a protein called FUS. Okay, excellent. Let's see if I can move this. I think you have to move it. Yeah. This slide emphasizes, and it only shows the tau story in chronic trauma. Yeah, thank you. So this slide shows the general classification into two major groups: the tauopathies caused by abnormal aggregation of tau, Pick's disease, PSP, cortical basal degeneration, and the different TDP43opathies. TDPA, usually progranulin mutation, TDPB, usually associated with ALS, and TDPC, almost always associated with the semantic or anterior temporal presentation of frontotemporal dementia. Next slide, please. Temporal dementia hits the frontal lobes and the insula and the orbital frontal cortex, and then more dorsally, the dorsolateral prefrontal cortex. by these neurons. There is leakage of the TDP43 protein out of the neuron, which is shown in brown, and into the cytoplasm. That the von Economo neurons are massively injured, very early, when atrophy is just beginning. Pyramidal neurons are almost completely spared. So as the disease spreads, we see spread out of the von Economo neurons and fork cells into adjacent. Let's see, next slide. This shows that it doesn't only happen with TDP43, but it also happens with tau. And we see abnormal tau aggregated in these fork cells and von Economo neurons very early in a tauopathy. Yeah. Thank you. Next. Yeah, I think we can go on to the next one after that. This is, I think, a big question yet is Asia going to see a lot of genetic mutations like the ones we see in the West or not? And I would say Taiwan is the place that will decide this for the rest of the world. In the West, we have three major mutations, MAPT or tau, progranulin, and C9orf72. Tau begins in people in their 50s, progranulin in people in their 60s, and C9orf also in the 50s. C9orf is the major gene associated with frontotemporal dementia and also with ALS. The progranulin is a gene that is causing haploinsufficiency. So too little progranulin is responsible for the neurodegeneration. In the case of MAPT, what we see is abnormal tau aggregating in the frontotemporal regions. So I think therapies increasingly are going to be happening across the world. At UCSF, Jennifer Doudna, one of the inventors of CRISPR, a Nobel laureate as well at our center, is developing CRISPR approaches to turn off the abnormal tau gene. In the case of progranulin deficiency, a number of companies are developing ways of bringing the progranulin protein into the brain. Denali Pharmaceuticals has started a recent trial where they have tied the progranulin protein to an antibody that is taken up by the transferrin receptor and delivers progranulin into the brain. And then finally, the antisense oligonucleotides are being used to turn off the abnormal gene that causes the C9orf72. Next slide, please. Yeah, next one. Good. So this is a major group, set of centers led by Brad Beauvais at Mayo, Adam Boxer and Howie Rosen in San Francisco. We have sites across the United States collecting data on patients with frontotemporal dementia. We need more patients for clinical trials. And that's why I think Taiwan will become so important in the future, because even with all of these dedicated centers in the United States, I don't think we have enough patients to really test the drugs that are increasingly available to us. So I think we are really going to need similar effort across Taiwan. Next slide, please. So this shows a conference that we had in 2012, and I don't think things have changed very much, but it pointed out that we have lots of genetic mutations in North America, Australia, and Europe. At the time, there were almost no familial cases of frontotemporal dementia in China, India, Taiwan, Japan had a few, but I think it is possible that some of these genes are predominantly present in Caucasian families. I am leading a new effort in South America, funded by the National Institute of Health, to study 2,000 people with frontotemporal dementia across the continent. And next slide, please. And this is this initiative, and we will be studying people who are indigenous peoples, the Indians of our continent, in Peru, in Brazil, in Ecuador, in Colombia, Chile. We will also be seeing people who are of African descent in Brazil and Colombia. And so I think we're going to get a better sense of whether these mutations or FTD is present in these populations. But I think we still need much work in Asia to look for genetic causes of frontotemporal dementia, whether they're different or whether they're the same. This is, I think, one of the large hurdles that our field faces right now. Next slide, please. So this is a slide I could show for just about any neurodegenerative disease, but I think what it is showing is that people start to aggregate bad proteins, molecular pathology, maybe 15 to 20 years before they actually develop symptoms of questionable impairment or a CDR of 0.5. That happens usually within a year or two in the case of frontotemporal dementia before someone develops full-blown symptoms. So I think you can see in the top blue line, it's many years of pathology aggregating before someone really starts to slide down a dementia pathway. We think before people are actually getting sick, they're starting to leak neurofilament from the axon of neurons. Brain volume is starting to diminish. And they're starting, in the case of frontotemporal dementia, to develop psychiatric symptoms, obsessions, disinhibition, sometimes called schizophrenia or bipolar, but it is usually the beginnings of a frontotemporal degeneration. Next slide, please. This shows work by Susie Lee, who looked at progranulin carriers, and what she found was something I think very interesting. She showed that within a few years before people becoming symptomatic, they started to develop on functional MRI hyperconnectivity. Progranulin deficiency can cause different clinical syndromes. It can cause a non-fluent aphasia. It can cause cortical basal syndrome. It can cause an Alzheimer-like syndrome, and it can cause a BVFTD syndrome. But in the years before someone becomes profoundly symptomatic, you start to see hyperconnectivity across these networks. We think this is the beginning of the disease, probably reflecting inflammation in the case of these patients. So imaging, I think, is going to be used in our major trials of frontotemporal dementia. Next slide, please. Good. Yeah. So atrophy can be detected fairly quickly. Once someone starts getting sick with frontotemporal dementia, they develop a massive atrophy. And so I think the MRI is also going to be used in clinical trials of patients with frontotemporal dementia. Next slide, please. So neurofilament, as you can see in the next slide, looks like it's a pretty good biomarker for at least 2 of the 3 genetic forms of frontotemporal dementia, and maybe all 3. So non-carriers are not injuring neurons. They show very low levels of neurofilament, and you can measure this in the blood. I think this is going to be an incredibly valuable tool in people who look after populations with dementia. Once you start to develop symptoms or mild behavioral impairment, the neurofilament rises, and granulin, tau, MAPT, and C9orf72. And by the time someone is symptomatic, they have massive elevations of neurofilament. So what we think is that if we have an effective therapy and it begins to stop the neurodegenerative process, we think not only will the neurofilament stabilize, but it may actually begin to diminish. So I think as we move into clinical trials, we really strongly believe that neurofilament will be one of the biomarkers that we will be using. Next slide, please. This shows nice work done by Caitlin Casaletto that suggests that we looked at 2 things. One, cognitive activities of gene carriers and physical activities. And I think the data is pretty compelling. She has also looked at this in Alzheimer's disease, and I think has 2 really good recent papers that suggest that in the case of Alzheimer's, cognitive activity and physical activity, even when someone has the Alzheimer's disease process, is protective and decreases inflammatory response in the brain. In the case, next slide, please, around lifestyle in FTD, gene carriers who were cognitively active and physically active showed very different curves. People who had low cognitive activity, you can see this dark, rather rapid decline. Thank you. And in contrast, above in red, there is relative stability, very little cognitive decline in people who are baseline active. The same is true for physical activity. People with high activity on the physical side show much flatter deterioration, whereas above that, you can see people who have low physical activity have a very rapid clinical decline. So Next slide here. This is Caitlin's work in Alzheimer's, and it suggests a possible mechanism. So what she has found is in Alzheimer's disease, in a correlation in a project with the Rush Group in Chicago, that people who were physically active and had better cognitive aging, and they showed less microglial activation. So physical activity seemed to be very important for diminishing the inflammatory component of neurodegeneration. So we have our own systems in the brain that protect us from neurodegeneration. And I think one of them is certainly physical activity. Next slide. This is, I think, very exciting, encouraging research. These are the research criteria that were international that we developed. And the first 6 items are the clinical features of BVFTD: disinhibition, apathy, loss of empathy for others, compulsions, overeating, and executive loss with visuospatial sparing. So to meet possible criteria, you need 3 of the 6. To meet probable, you need to also have atrophy on the MRI. And to meet definite, you need these clinical criteria plus the addition of a known mutation. These are criteria that, even though we developed them in 2011, are being used now in clinical trials for frontotemporal dementia. Next slide. This shows you the orbital frontal cortex. Work done in mice by Rolls and collaborators in England. But it basically shows that our orbital frontal cortex has 2 pieces. It has a medial piece, strongly connected to hypothalamus, very strongly connected to reward. And when a mouse or a human is seeking reward, that part of the frontal cortex is very active. The lateral orbital frontal cortex is much more involved with saying that we no longer need that reward. They've used the term punishment. And so what happens in BVFTD is this whole orbital frontal cortex is decimated. We see abnormal reward seeking, overeating. Elisa Resende recently had a very nice paper where she showed that in the United States, about 7% of our patients with FTD began with alcoholism as a first symptom of the disease. This was much less common in Alzheimer's. So I think addictive behaviors are sometimes very, very prominent in FTD. People become addicted to shopping. They spend many hundreds of thousands of dollars. So they seek that reward. They don't worry about the punishment. And sadly, in many families, people go bankrupt because of the disruption of the orbital frontal cortex. Next slide, shows another consequence of this altered reward punishment system associated with frontotemporal dementia. And here we show that close to 40% of our patients with BVFTD committed a crime that either led to their arrest or could have led to their arrest. And whenever I hear of someone being arrested for a silly crime after the age of 50, I always think about frontotemporal dementia. It's the disinhibition that leads to the abnormal behavior. Next slide is work that I'm very excited about. Kate Rankin has done work here, Virginia Sturm. Very exciting work that shows that the right anterior temporal lobe is critical for our humans' ability to empathize with other people. So what we often see in BVFTD is loss of empathy for people around us, cruelty to children, cruelty to animals, lack of caring about hurting our loved ones' feelings. This leads to divorce and, extremely deleterious effects on the family, all driven by very focal neurodegeneration. We can go through the next slide quickly, these are people who've studied emotion in the brain. Virginia Sturm in the next slide has shown me tremendous abnormalities in behavior related to the autonomic nervous system. So yeah, next slide. And what we see in BVFTD is lack of embarrassment, lack of disgust, even effects on the parasympathetic and sympathetic activity. And if you can just click, yeah, I don't think we can click through this, but the bottom line is the parts of the brain that allow us to flush, to allow us to feel disgust, are not activated, and leading to this very abnormal set of behaviors. Next slide. So parasympathetic activity is a very important driver of behavior. And we know that when we are engaged in pro-social, loving behavior to people around us, we show higher vagal tone or heart rate variability, social engagement, empathy, emotion regulation, positive emotion, agreeableness, optimism, pro-social behavior. That's all driven by parasympathetic activity. And this is altered very early in frontotemporal dementia. So the Dalai Lama, one of the greatest humans who has ever lived, says, be kind whenever possible. The Dalai Lama says it is always possible. You know, we can think of world leaders who capture this parasympathetic activity. And sadly, in our current news, world leaders who have no concepts about what humans are really meant to do. Next slide. So we found in this study that the loss of empathy in FTD caused relationship turmoil. It was greater in FTD than any other dementia. Empathy loss was associated with marital dissolution, and BVFTD patients who experienced marital dissolution or infidelity had significantly lower empathy scores than those who did not. I think a few more slides, and then Judy, you tell me when you think I should stop. I think I've been speaking a long time, but maybe a few more slides, and then maybe I could take some questions. Okay, so this is really interesting work that comes out of the Levinson lab. We have a Taiwanese investigator, Kwa, who is doing beautiful work in this space. But basically, what this slide shows is that we can tell in caregivers, in families, whether they are going to have physical illness or global health changes or psychiatric problems based on where the brain is attacked in their loved one. So the punchline here is if your loved one has disease in the frontal anterior insular regions, you are more likely to have a physical illness, depression, anxiety, dysphoria, distress. It is not only psychiatrically dangerous, it is even physically dangerous. So this tells us that frontotemporal dementia is probably the most debilitating neurodegenerative disease that we have. Terrific. Next slide. I'm not going to go into too much detail about this, but I'm just going to make a general comment about this slide. So a philanthropic family in the United States, the Richards family, who are interested in curing progranulin mutations, funded a group of investigators. Bob Faris made progranulin deficient mice that we have studied. Eric Roberson and Lee Gann studied the behaviors of these mice. They had abnormal nest behavior. They had abnormal passivity in certain behavioral tasks. Lee Gann and Amy Gao at UCSF, a family originally from Taiwan, has studied progranulin pathways and has shown that inflammation is a very prominent part of this disease. We have looked for drugs through this consortium. Eric Roberson is showing that with virus transfection that you can improve the mice with a progranulin cell. We have thought a lot about the earliest stages of the disease with Howie Rosen, Susie Lee, John Van Swieten in Holland. We've got large numbers of neurons derived from progranulin deficient patients. We've thought about the genes that increase, decrease susceptibility. And I think one of the major findings from this, and I think this is relevant to all neurodegenerative diseases, is progranulin deficiency causes dysfunction in the lysosome. So what happens is the cell cannot get rid of the bad proteins. So they aggregate, they cause damage in the lysosome, and they eventually kill the cell. I can tell you there are 6 companies now beginning clinical trials for progranulin deficiency, and I think this group of dedicated people had a major role in bringing clinical trials into this field. And I think I'm going to move through these slides rather quickly. I might just focus on one, the work by Eric Wong, who is we'll go on to the next one, Taiwanese originally. So this is Amy's work that shows that when you are deficient in progranulin, your microglia become angry and activated. They release cytokines, and with complement, they injure neurons. Go 2 more slides here. Yeah. So the mice are just like us. And so the mice develop OCD-like behaviors. They scratch themselves. They have abnormal nesting. The humans have similar behaviors. We think from the work of Eric Wong, which is shown on the next slide, that actually that this is driven by the complement that is produced associated with the inflammation. Yeah, great. So what Eric showed, I think in rather brilliant work, was that the first sign pathologically that the mouse was getting sick was abnormal inflammation in the thalamus. This microcircuit was associated with OCD-like behaviors such as abnormal scratching in the mouse. He showed if you knock out the complement gene, even if you have a progranulin deficiency, you do not get sick. And you can even restore this if you knock it down after the inflammation has begun. So I think I might stop with this slide here, make some general comments about the disease. So it's a fascinating disease. It's not unlike the other neurodegenerative diseases. It has a prodrome, early symptoms, and then disease. I think we are getting very good biomarkers for preclinical Alzheimer's. They are beginning to emerge with frontotemporal dementia. I think we will have them in a few years. But more exciting, I think we really have tremendous targets. I think that the field is really activated to develop therapies for patients with both genetic and sporadic forms of frontotemporal dementia. I believe this will be the first neurodegenerative disease where we start talking about a cure. And I think this will be happening in the next 3 to 4 years. I think at a human level, for families, this is the most devastating disease. And I think back to my last visit to Taiwan and the tremendous care that you have across the island for patients with this disease, the social networks that have been developed to make sure that these people do not suffer. During the times of COVID, I worked with a number of investigators in South America. And unlike Taiwan, I think many of these countries, people were not vaccinated. And watching how devastating frontotemporal dementia was in the setting of COVID, nothing was more difficult than caring for a loved one with frontotemporal dementia when you're worried about COVID. So anyways, I think you have an incredible healthcare system. And I'm hoping that we will work together and begin to find cures for these age-related neurodegenerative conditions. I think maybe I should stop there. You're very patient for staying with me tonight.
Thank you, Professor Miller. Okay, we can take a few questions. I think Dr. Lin Yongxuan, you can raise your question. Please open your microphone.
Yongxuan is left for work, and her question is on the screen.
Okay. Dr. Lin asked about the inflammation. Is it occurred only after the disease appear, or the inflammation begins since the preclinical stage?
Yeah, I think it probably is the beginning of frontotemporal dementia caused by progranulin. I've asked Eric this. He's really the world's expert on this. But Eric thinks that the deficiency in progranulin leads to the activation of microglia. Then the microglia release cytokines, and then that sets up this inflammatory phase where neurons and microglia are being injured. At the same time, the cell is less able to take care of misfolded proteins. So the lysosome is injured second, and then this lysosomal process is also part of the neurodegeneration. But I think it's a good question. I think it probably is beginning preclinically. And I think the better we can get at figuring out when exactly a disease is starting to take off will be very important for therapies, because I think some of our therapies are going to be very invasive.
Okay, thank you. My question is in my experience, the progranulin deficiency is not easy to diagnose. Do you have any suggestion for the clinician to find out this kind of patients, especially in the clinical setting?
Yeah, well, I think right now we have a number of companies that are very interested in capturing the genetic profile of populations. We have a company in the United States called Invitae, and they are actually doing full genome for us on any patient. that we think may have frontotemporal dementia. And I would bet that is available to you in Taiwan as well. But I think that when I started doing research in this space, we looked at patients and did about 20 genes that we measured. And I think we have a dementia panel that we use, but they're costly. And I doubt they're covered by your insurance company because they aren't covered in the United States, that's for sure.
Mm-hmm. Yeah. Well, I think there are few hospitals have their own dementia panel, genetic test. Yeah. It's also cover about 20 genes. Okay.
I see.
Mm-hmm. Are there any questions from the audience?
Yes, Bruce, this is Judy. So you just mentioned that at UCSF, FTD has 80% being tau. Just wondering, is that from pathology or image finding or its genetic testing results?
Yeah, so the non-fluent variant, about 85% are tau. Of that group, 50% of the tau are cortical basal degeneration. So cortical basal degeneration is the most common cause for non-fluent progressive aphasia. We then have learned that most of the others that had TDP actually had a progranulin mutation. So I think this is important for clinical trials. So if you can take with a relatively uncommon disease all the tauopathies and treat them, for example, with CRISPR against tau, you might get the numbers that you need to do an effective treatment. So that's our experience with the non-fluent aphasias. It's pathology proven, and I would bet it's similar in Taiwan. Judy, what is the most common FTD syndrome that you see? Is it the behavioral variant?
Yes, it's the behavior variant. And I saw that from the tau imaging, the tau deposition would indicate whether there are frontal variant. Because semantic dementia, they have very few percentage of tau positive, although we did see some non-fluent patients that also have tau, and the tau deposition is not Alzheimer's. Yeah, so it's a frontal variant.
Exciting. And so you're doing tau PET, it sounds like, in Taiwan.
Yes. We are doing tau PET. Great.
I'd love to think with you more about that. We have some new agents that are being developed, but I think we'll do better in the coming years. Yeah.
Thank you.
Well, I really apologize. I'm going to have to talk with my IT people about why my computer is not accepting Cisco WebEx meetings, but you're the second one I had today that this happened. I take my fault. I apologize.
It's okay. So because the time is limit, we want to close this talk here, and we hope in the near future Professor Miller can visit Taiwan after the pandemic.
I would love that. I think it's coming to a close, but nobody did it better than you. Congratulations.
Mm-hmm. Thank you. Okay.
Thank you.
Bye. Thank you. Goodbye. Goodbye, everyone. And also thanks all the participants and your patients. Thank you. Bye-bye.